Welcome back to Neurology 101 on the ProPA podcast. I'm Dr. G, and today we're starting our sub-series on dementia, beginning with the most common type, Alzheimer's disease. You've likely heard of it, may know someone affected by it, and as a PA, you'll definitely manage it. Let's break it down with the clarity it deserves. Did you know that Alzheimer's disease accounts for 60 to 80% of all dementia cases? And it begins years, even decades before symptoms appear? 1 in 3 seniors dies with Alzheimer's or another form of dementia, making it one of the top 5 causes of death in the United States. As a side note, my grandmother suffered with dementia and Alzheimer's disease for about 15 years of her life, and we as a family slowly noticed the progression little by little from forgetting things around the kitchen to forgetting she already ate. And then it progressed on to where she was essentially immobile and non ambulatory and had to be cared for 24/7. Eventually, she ended up slipping out of her bedside commode and breaking both of her femurs, which led to her passing. I don't say this to make a sad story, but it is really common, and you'll likely have many patients affected by this disease, whether it be them that have it or patients that have a family member suffering from it. Some say that Alzheimer's disease is actually harder on the family because they have to witness their loved one progressing. All right, now let's look at the kinder patho. What is Alzheimer's disease? Well, it is a progressive neurodegenerative disorder marked by the accumulation of beta-amyloid plaques, which are extracellular, and neurofibrillary tangles of tau protein, which are intracellular. These lead to neuronal loss, especially in the hippocampus and cortex, which impairs memory, language, and eventually motor and autonomic function. It is characterized by gradual onset and continuous cognitive decline that interferes with daily functioning. So, how do these patients typically present? Well, some of the early signs of Alzheimer's includes short-term memory loss, word-finding difficulty, and subtle personality changes. As the disease progresses, we might also notice impaired executive function, disorientation, difficulty with activities of daily living, and later motor dysfunction, incontinence, and even mutism. Preservation of social graces early on can delay diagnosis. So, how do we diagnose Alzheimer's? Well, it is a clinical diagnosis based on history plus cognitive testing. We want to perform the MMSE or the MoCA to assess for severity. Functional decline must be present. We might also consider getting some imaging like an MRI or CT, which might show cortical atrophy, especially in the temporal and parietal lobes. This also helps us rule out other structural causes. Labs to rule out mimics include TSH, a B12, an RPR, HIV, CBC, and CMP. The definitive diagnosis is postmortem, but clinical confidence is high with consistent presentation. How do we treat Alzheimer's? Well, first we want to consider symptomatic therapy. We can give acetylcholinesterase inhibitors like donepezil for mild to moderate disease, and we can also give the NMDA receptor antagonist like memantine for moderate to severe. We also want to consider supportive strategies like keeping the patients in a routine, monitoring for safety and making those modifications, and caregiver support. We also want to do some advanced care planning with the understanding that the disease progresses over time. We also want to treat comorbid conditions and avoid anticholinergic medications. All right, so let's look at the book med versus the street med. Book med, gradual memory loss, cortical atrophy, treat with donepezil. Street med, your patient's spouse says he's just been forgetting little things, but you notice he repeats his stories, gets lost in familiar places, and is socially withdrawn. You run labs, rule out B12 deficiency, and catch Alzheimer's early, before a crisis. All right, now let's look at some clinical pearls. So Alzheimer's equals gradual onset and progressive decline. Most common first symptoms are short-term memory loss. We want to rule out reversible causes like vitamin deficiencies or hypothyroidism. Cholinesterase inhibitors help with cognition, but they're not a cure. And we want to involve the family early. Caregiver burden is significant. All right, now let's do some PANCE-style practice questions. A 76-year-old woman presents with memory loss and difficulty managing her finances. Her MMSE score is a 22. MRI shows temporal lobe atrophy. What's the most likely diagnosis? Is it A, vascular dementia, B, Lewy body dementia, C, Alzheimer's disease, or D, frontotemporal dementia? Shouldn't take too long to get this one right. It is C, Alzheimer's disease. Gradual memory loss plus cortical atrophy equals Alzheimer's. Which of the following medications is most appropriate for treating moderate Alzheimer's disease? Is it A, sertraline, B, donepezil, C, haloperidol, or D, levodopa? I'll give you a few seconds. If you said B, donepezil, you are correct. So anticholinesterase inhibitors are the first line for Alzheimer's. So some final thoughts. Alzheimer's disease is a common, complex, and often missed early. But with the right tools, PAs can detect it sooner, support families better, and plan proactively. Don't just memorize. It's a condition you'll truly manage. In the next episode, we'll cover Lewy body dementia, a close cousin of Alzheimer's, but with some crucial differences. If you found this episode helpful, leave us a quick review or send it to a classmate prepping for neuro. And as always, this is the Pro PA Podcast, where future pros in medicine are made. Until the next episode.